Hello and welcome to Let's Talk, a Tulsa World virtual town hall meeting. I'm Wayne Green, editorial pages editor of the Tulsa World. Today's town hall is graciously underwritten by the George Kaiser Family Foundation. Today we're going to be talking about the COVID-19 pandemic in Tulsa County with Dr. Bruce Dart, Executive Director of the Tulsa Health Department. Welcome, Dr. Dart.
Thank you, Wayne. Appreciate being here today.
We asked our readers what questions they'd like to see asked today, and the response is frankly overwhelming. I want to get to as many of those questions as we can. First, Dr. Dart, there seem to be a lot of questions about COVID-19 testing. Who can be testing? Who can be tested? When will at-will testing be available for everyone, not just those who are showing symptoms? And why is Oklahoma's death rate among those who have tested for tested positive for COVID-19 so high relative to the rest of the nation? And what is the value of testing if someone could be infected moments after they take the test?
So we're at this juncture, we're still focused on testing those who either have symptoms of COVID-19 or those who have had known exposure to COVID-19. And the reason for that is that while we are getting a large number of test kits in our state, our labs have a greater capacity to test, we still lack the resources to have the appropriate number of swabs to actually do sampling and what we call the viral transport medium. After we swab a patient, we put the swab in viral transport medium, and that's how we get that specimen to each laboratory. And until we have enough collection kits, we're still going to have to maintain more of a closed monitoring system to determine who can actually get the test. Once we get a great number, a higher number of collection kits, then we'll start expanding testing to almost anyone, because testing is important. It's important to know where the virus is, and it's also important to know where the virus is not, and that's what testing will help tell us. We've had a lot of questions about why we seem to have a higher death rate here in Oklahoma and Tulsa County, and part of that is because, as we know, we weren't really high on the list of healthiest states. We have a lot of people here who have what we call underlying health conditions or chronic disease conditions, and which really impacts their health status. And when you're not as healthy as you could be and you're exposed or infected with a new or a different virus, then it makes it hard for you to recover. I think part of this, it will allow us to really talk about ways that we can change lifestyle and health status here in Oklahoma and Tulsa County, and really use this information to get people to make better health choices and live healthy lifestyles. So God forbid this ever happens again, our immune systems and our health status is more prepared to deal with a pandemic of a novel virus of any kind.
Is there any sort of timeline at this point on when the testing capacity will be up to where it needs to be?
There really isn't, and mainly because from a supply perspective, this entire country is drinking from the same well. So everyone is asking for these supplies. And I think our manufacturers are doing a great job of ramping up their ability to create these supplies. But bottom line is that with the demand so high, the supply just isn't there. And once the manufacturers catch up and we have the ability to have the resources to test as many people that need to be tested, we're definitely have plans to do that. But once again, until we expand manufacturing, we're going to be where we are today.
There's a lot of talk on the national media about antibody testing. Is that available in Tulsa County, and what's the value of that?
There's some private companies we know are doing antibody testing, and frankly, the science is still not really clear on antibody testing, mainly because what we're finding is that the FDA has several approved test kits. There's also been quite a few that have kind of rushed through the FDA approval process. And we're finding that there's some reactivity or cross-reactivity between the various different coronaviruses that are circulating in the community. So we're not really sure of the reliability of all antibody testing. And that doesn't mean that every test kit is flawed, but the science hopefully has to get better. And, we're also still finding out that an announcement came from the World Health Organization this past weekend that we're not really sure that even if you've been infected and your body has seroconverted and produced antibody, we're not sure how immune you are to that. We're not sure how long immunity lasts. So this also gives us an idea for, are you immune for a year, 2 years, 3 years, and the antibody testing helps us determine all that.
One of our readers asked an pretty basic but interesting question about how infections work in a population. We see these graphics that show a peak of the virus and then a decline. There's no vaccine, there's no treatment. What causes it to decline?
So right now, our greatest tool in our weapons of our arsenal, so to speak, is social distancing. And if people aren't together, if we can break the chain of transmission, we're going to see a decline in the numbers. And we have been doing, I think, a really nice job of staying apart to the degree that we are seeing some break in that chain of transmission. But I think that the messaging might be a little confusing now. We're still in the middle of this pandemic. We're still in the middle of seeing virus circulate in our community. So it's important that we continue to keep ourselves safe, continue to social distance, continue to be very aware of our hand hygiene and hand washing. And if we continue to use these tools in lieu of vaccine and medicine, we can hopefully be more successful in breaking that chain of viral transmission. So this is not over. We need to continue to stay apart. And do so in a way that allows us to hopefully in some capacity restart our lives, at the same time keep ourselves safe.
That leads kind of naturally to the question that another reader asked that you may not have a satisfying answer to, but when is it going to be safe for the vulnerable population, the elderly, the people who have underlying health conditions, to leave their homes and return to normal activities?
So our modeling is showing us that we're seeing a peak of cumulative infections, total infections, probably coming through the summer. So, it's through the summer, we're still going to have to be, I think, very vigilant for our most at-risk populations, our elderly, our populations with underlying health conditions or immunocompromised conditions. And I wouldn't really plan to be resuming normal activity or rekindling a life until probably this fall, because we're still going to see viral transmission. As we reopen up, we'll see, I think, probably somewhat of a surge as people will be coming back together, which could promote new infections and help that chain of transmission exist. So I think for those who are most at risk, and I'm almost in that category myself, we have to be very vigilant. We have to take great care. We can go out in public without wearing a mask and pay close attention to hand hygiene and sanitizing.
So speaking of the projections, a question that came from someone who identified himself as a doctor points out that some of the health department's projections have been high in terms of hospitalizations and deaths. Do we understand what's going on there, and do you have a more refined forecast now?
So we're constantly readjusting our modeling, and our modeling is just based on how many people one person can infect if they're infected. And the more people stay apart, we're able to lower that number. We call this an R-naught number. And we started out with our initial projections that are R-naught showing that one person could infect 2.5 people whenever they came in contact with people, which makes our projections rise. And we have to remember that, modeling is based on, we approximate these numbers, and the more people stay apart, and we look at mobility data to see if people are staying apart, then we're able to reduce that what we call that R-naught number. So we're able to reduce that number and I think have a closer approximation to what the true numbers are about people being infected. And the thing we have to remember is that we're projecting all infections, and just because people aren't showing symptoms doesn't mean they're not infected. So while people aren't our numbers of those who are being tested aren't meeting those approximations, we think we're fairly close in approximating the number of people that really have been infected, who just are either mildly ill or asymptomatic. And we feel when it comes to being, we're approximating, we would rather approximately be close most of the time than be exactly right occasionally. So we think we're approximately fairly close to what our community is actually experiencing. And until we're able to really open up and expand testing, we won't know that for sure. And that's why we continue to refine our modeling numbers and constantly looking at our modeling data, so that we hope we're doing the right thing at the right time for our community.
So another question that came from a retired physician says that her members, of her friends and family are looking back and recalling unusually severe respiratory illnesses this winter, which were not the flu. And she's wondering if the virus might have been in the community earlier than we think, and if that might pose a risk for the disease spreading now. Now, I'm going to tell you, I've gotten several variations on that same questions from people who talk about having a cough that they just could not shake long before the virus supposedly was in North America. Is there anything to that?
We've actually heard that quite a bit. And, if you look at the data, I think in this country, our first cases were starting to be identified and confirmed in January. We had our first case here, we announced on March 6th. So I think it's perfectly safe to say that more than likely it was circulating here before we started actually testing it. Early on, we were in the middle of our flu season, and the flu symptoms closely mirror COVID-19 symptoms. So I wouldn't be surprised if it was circulating in November, December, January, of course, and until we start actually testing for it and seeing cases in February, March. So and I doubt that just suddenly appeared. So I'm sure it was here. I wouldn't be surprised if most of the people who might have been affected back then, before we were testing more broadly, if they had mild presentations or asymptomatic presentations. So it's not surprising. And I guess I'd be more surprised if it wasn't here late 2019 than prior to us actually starting testing for it in February, March.
Do we feel certain that about that once you've recovered from the infection, that you're not that you can't transmit it any further? That if you had it in November, in February, you're no longer going to be transmitting it to someone else?
And the science still isn't really clear on that. As I said before, we know that people who are recovering are producing antibody. Not everybody is testing negative, even though they have produced antibody and are no longer sick. We feel pretty confident that people who have recovered are not shedding virus. What we don't know is that does that antibody confer immunity on people so that they can't be reinfected? And we're getting a lot of questions about people who were sick maybe a month ago or longer, seem to have recovered, were doing fine, and suddenly are sick again. So we don't really know if people are being reinfected or if we're just seeing relapses. But what we are and sure about is that any viral load for those who are recovered, if they're shedding any viral load, it's so minimal that it poses extremely minimal risk. So we're not as concerned about those individuals posing a risk to the community. But the science we're still learning more and more about this virus. And it's been an amazing virus in that it's really been able to adapt and change more so than what we're normally used to. So it's forced us to be somewhat, I think, flexible in how we approach it.
A physician wrote and was curious about how the contact tracing process works. In fact, there were several questions about contact tracing. What are we talking about here, and who's going to be doing it? And how much authority do they have to tell people, you need to get tested, you need to be quarantined, you need to be out of the population?
So, contact tracing is one of the basic epidemiological tools that public health has deployed since early in the public health profession. And what we do is that we, by law, all these diseases are reportable to the state. The state notifies us as we're we have jurisdiction to cover Tulsa County, and we contact that patient. And we do it over. It's somewhat labor intensive because we ask patients to trace their steps back from 2 days prior to onset of symptoms to 14 days beyond that. And it's really impossible, I think, to recall everything you were doing 2 weeks ago. So these contacts happen over a series of time, a series of multiple phone calls. They're really extensive so that we can get a really solid feel and as much information as we can gather about where that individual has been in these 2 weeks, so that we can then turn around and contact people or organizations or any places that might have been in public settings. We can warn them. We can identify that they might have been exposed. We can get them in for testing if they need it. We can quarantine them if we have to, or if they're sick, we can test them and isolate them if need be. So, and the public health statutes give us the authority to actually do this. But our primary goal is to protect people and notify people and keep them safe. And it's amazing. We found out that the average individual in the course of contact tracing has probably been in contact with 35, 36 people. And that's the average. We've seen as high as over 100 either people or organizations that they've been in. So it's extremely labor intensive. We start out with 4 people here early on in this response doing contact tracing. We now have 25 people doing contact tracing, and knowing that as we rekindle society, there's a good chance that if people start coming back together, we're going to start to see probably a ramp up, and hopefully just temporarily, in the numbers of cases. So we have an epi plan to also ramp up our contact tracing if that takes place.
Just to be completely clear, contact tracing is a job for the health department. That's something that your people will be doing.
Absolutely, and that really is, from a public health perspective, it's been done in local health departments, state health departments since the public health service started in the late 1700s. So it's one of our very basic public health tools that we've always done, and we do it really with any reportable disease or disease that can be transmitted from person to person. We've been doing contact tracing more than just with COVID-19, and we continue to do contact tracing for the reports that we continue to get to this day that aren't COVID-19.
So several people wrote to suggest that we need sort of an intermediate sort of facility for people who might or might not be contagious, but don't need hospitalization, but need to be, perhaps people who've been in nursing homes, but can't go back to a nursing home. Do we need to start repurposing hotels or something for that use, Dr. Dart?
So we actually have been working very closely with TAMA, the Tulsa Area Emergency Management Agency, and of course National Guard, and we've been looking at hotels and other alternative care sites for people that need to go someplace, and whether they be quarantined or just have a place to go until they're negative and can be readmitted back into a long-term care facility or whatever, knowing that people can't always go home. We need a place to care for those individuals who have no other alternative. So it's part of our planning. We've been doing this in concert with great partners, and hopefully if that happens, we'll have space for people who need it.
So kind of a critical question here as we prepare to reopen society is, what's our metric for deciding that we've gone too far, that we need to tighten the reins back down and bring people back into their homes? I mean, it's reasonable to assume that the number of people diagnosed, the number of people hospital, and even the number of people who die are likely to go up. How do we judge when we've gone too far?
And that's a really good question, and it's a question that we're actually trying to get answers to as well. We're trying to figure out the specific metrics that we need to look at. So just generally, off the top of my head, if we come to a situation where we can't expand our testing to meet all those who've been exposed or who have symptoms, if we can't maintain our ability to do contact tracing, that's going to be an issue. And then just the pure numbers. We look at our models, we look at our numbers over 4-day rolling averages, and if those 4 or 7-day rolling averages start to increase or even double what the previous trends have been, then we know that we have to get really serious about maybe pulling back a little bit and looking more seriously at reinstating some shelter-in-place recommendations. And so those are the general metrics. So hopefully we'll have something much more specific, and we've got our data people working on that right now as we speak.
You didn't mention hospital capacity in that. Are you confident in the capacity of our hospitals to handle another surge? Well,
and you're absolutely right. And so far we meet with our hospitals weekly. We have a great relationship with our hospitals. We talk to them more than weekly. And right now they're telling us that they do have the capacity, but of course that's an important metric that we have to look at. And as if we can't maintain testing, we can't maintain contact tracing, then it's also probably telling us that hospitals are surging and their capacity is probably becoming critical. So of course, hospital capacity we did the shelter in place in the first place to help our hospital systems ensure that they would not be overwhelmed. So of course, that's one of our really critical metrics, and that's something that we look at over time.
So I want to thank Dr. Bruce Dart for joining us today. Dr. Dart, you've helped us understand the situation better and think through some critical issues as we prepare to reemerge from the COVID-19 shutdown. Thank you to our viewers today and to our sponsor, the George Kaiser Family Foundation. Please join us again next week for our next Tulsa World Let's Talk virtual town hall, featuring leaders of Oklahoma's higher education system discussing how they will deal with the COVID-19 crisis. I'm Wayne Green, editorial pages editor of the Tulsa World. Goodbye for now.